The information presented in this presentation is not a substitute for examination, diagnosis, and medical care provided by a licensed and qualified health professional. The opinions expressed by this speaker do not represent those of Advent Health. Please consult your physician before undertaking any form of medical treatment and/or adopting any exercise program or dietary guidelines. If you think you may have a medical emergency, call your physician or 911 immediately. Thank you for joining us for this Advent Health virtual seminar. We hope you'll find the material presented helpful and informative.
Good afternoon. I want to thank you for joining me for this presentation. My name is Karl Siebuhr, and I'm an orthopedic surgeon, and I practice out of Ocala, Florida. The name of my practice is Reconstructive Orthopedics of Central Florida, and I am very pleased to talk to you today about advances in treatment of hip and knee pain. So in my introduction, I'd like to tell you a little bit about myself. I was raised in Nebraska in the Midwest, and I have a farming background. And from there, I was transplanted to the University of Nebraska, where I studied pre-med and biology. From there, I went and obtained a master's degree in physical therapy in Indiana. And then, because I didn't think that was challenging enough, I went on to medical school at Wright State University in Dayton, Ohio, went on to residency in Ohio, and then completed a fellowship in San Francisco in orthopedic trauma, and then several traveling fellowships after. And so it was a very enjoyable experience, and I learned a lot and became a much more well-rounded surgeon as a result of all these experiences. So, and I also have an additional 15 years of experience in orthopedics, trauma, and joint reconstruction. So this is where I practice in Ocala, Florida, where I launched Reconstructive Orthopedics of Central Florida in July of 2020, right in the middle of the pandemic. And so I mainly practice out of Advent Hospital of Ocala, Florida, as well as Ocala Regional Medical Center, where I'm core faculty at the UCF residency program, and as well as help to run the orthopedic trauma service line at Ocala Regional Medical Center. So this is my mission, to treat one patient at a time. My primary directive in the trauma center is to mend bones, or taking care of bad injuries and bad fractures, and also helping patients restore their lives through helping them with their problems with their joints, with arthritis, whether it be post-traumatic or rheumatoid or gout or whatever the etiology is. We address their problems one at a time so that they can get back to living fully active, healthy, and productive lives. And so we're going to talk a little bit about knee and hip pain today. We'll start with knee pain. It's one of the most common causes of knee pain. And so I'd like to talk to you about your treatment options for that, what to tell your doctor, what your doctor should be asking you as far as what your expectations and goals of treatment are. So some of the common causes of knee pain, trauma, I see a lot of that at the trauma center. So post-traumatic arthritis from fractures about the knee. There's non-traumatic causes of knee pain as well, including infection, arthritis, osteoarthritis, rheumatoid arthritis, and gout. And so we'll talk a little bit more about osteoarthritis, because that is one of the most common causes of knee pain. It affects up to 27 million Americans, and it's usually due to wear and tear, and it usually starts after about the age of 45. And you can see the cartilage becomes damaged. You get secondary changes about the periphery of the joint with bone spurs or osteophytes that form, and you can also get such severe disease that you get deformities about the knee as well. And so some of the symptoms that you can expect are a stiff or swollen joint, stiffness in the morning or after inactivity. This pain may cause a sensation of buckling or weakness, and many patients report changes in their symptoms with changes in the weather. So you can also get, as you can see it from this picture of a patient, some rather severe deformities. So this is called a varus deformity or bow-legged deformity. And that's from one of the most common causes of knee pain, which would be medial compartment arthritis. And so you can also get what's called a valgus deformity or knock knees, where the knee joints almost touch, or they can touch sometimes. And that's from lateral compartment disease or pain on the outside. You can also get varying degrees of medial and lateral compartment arthritis, as well as patellofemoral compartment arthritis for a variety of reasons. And so as part of your normal evaluation, your doctor should be ordering x-rays, and these are usually weight-bearing x-rays if the patient can tolerate standing up on their painful extremity. And so you can see on the left-hand side of the screen is a normal knee joint. So you have normal knee joint spaces. The white part is the bone, because that's where the x-rays don't penetrate. And then between the two bones is the joint space, and that's represented by cartilage. And that's the black space between the femur part of the bone and the tibia part of the bone. And so you can see a relatively normal knee joint there. The black spaces between the two bones are relatively equal. Whereas on the right, you can see you have some bone spurs that are starting to form, as well as narrowing of the joint space. And so these are some of the most common findings in knee osteoarthritis x-rays. And so as part of the treatment for this problem, your doctor should be talking to you first about non-surgical options. So physical therapy and graded exercise certainly play a role, as do injections of various different kinds of medications that can be used to control the symptoms of arthritis. Unfortunately, we do not yet have a treatment that will restore normal articular cartilage into the knee joint itself. But we do have some medications, at least 3 or 4 different types of medications that can be injected into the knee, which will sometimes control symptoms to a significant degree for patients for a long period of time. Bracing and heel wedges also have their place, although the literature is a little bit more controversial about that, but some patients get relief from that, as well as glucosamine chondroitin sulfate, over-the-counter alternative medications, which as long as the medications are safe, I don't have a problem with my patients using that in my practice. So there's also surgical options. One surgical option is arthroscopy. It has a somewhat limited role in the management of osteoarthritis. It's used for very mild to no arthritis in patients with mechanical symptoms, and that's usually due to a meniscus tear. And you can see on the picture on the upper right, this is a representative picture intraoperative of a knee arthroscopy, and you can see the meniscus is labeled. Frequently that's torn, and it's called the degenerative meniscus tear, which can cause significant pain, swelling, and mechanical symptoms, and that can be effectively managed with a knee arthroscopy. Now, when the knee joint cartilage becomes so damaged that you can see bone, then a knee arthroscopy is a very ineffective treatment for that problem, and your doctor will probably talk to you about other options. So when is surgery right for you? It's when you have progressive symptoms which restrict your daily activities, you have severe pain at rest, chronic pain and swelling that does not improve with the rest or medications, a knee deformity, and then failure to improve with medications, injection therapy, or other surgeries. And only the patient and their doctor in a shared decision-making process can make the decision when that surgery is right for each individual patient. So there are basically 2 options for treatment of bone-on-bone arthritis. And the first is on the left, you can see medial compartment knee arthroplasty, and that's for that medial compartment disease with correctable deformity and with intact ligaments. And that patient is a good candidate for a medial compartment arthroplasty. And the advantage of that operation is it is just less surgery. So the surgery is quicker, the recovery is quicker, and the risk of complications is less. On the right-hand side of the screen is your traditional total knee arthroplasty, and that's a resurfacing of the entire knee joint, which is an excellent treatment, and a lot of patients get very good relief with that. But that's indicated primarily for patients with tricompartmental disease or patients with disease all throughout their knee joints, because it addresses all the problems that are occurring in the knee at the same time. So your doctor may need to do additional testing to make sure that surgery is safe. And that can include cardiac consultations, some additional lab work to make sure that the blood work is all within normal parameters, and then sometimes evaluation by the primary care doctor to make sure that any chronic medical conditions or correctable conditions are adequately addressed prior to surgery. So this is the actual component that I use for partial knee replacement. It's called the Oxford partial knee replacement. And it's just for patients with isolated arthritis to the medial or lateral side of the joint. And it has a mobile meniscal bearing that fits between the two components. And if we'll back up a knee slide or two, you can see that fine line between the femur and the tibia in the picture on the left, and that represents the knee meniscus bearing, which moves as the knee joint moves, and it helps to facilitate a smooth gliding motion of the knee so that the knee mechanics feel much more natural. And so you must meet specific criteria to be a candidate for this procedure, and your doctor would be talking to you about what that criteria is prior to scheduling any kind of surgery. And then there's total knee replacement, and this is complete resurfacing of the joint. It can be done in many different ways, but the midline anterior incision is the gold standard for obtaining exposure intraoperatively. Now, once you have a patient in the OR and you are implanting the knee, you have to get the alignment correct or the surgery won't turn out right, and that can be done in a variety of different ways, including intraoperative jigs, preoperative CTs and MRIs, and then robotic assistance. And so in my practice, I use patient match technology where we obtain an MRI preoperatively, and that's uploaded to the factory, and then custom alignment jigs are matched to the patient anatomy and then shipped back to the hospital in preparation for the patient's surgery. And then there's the robotic piece of the equation, and I think that's probably where we're going to be moving to in the future. We have imageless guidance. You can obtain all of the necessary data entry points intraoperatively, and you can reproduce the knee CT scans and MRIs, and it's less, it is not as time consuming for the patient. It's a little bit more convenient because you don't have to send patients all over town for CTs and MRIs and then wait for the turnaround time for the custom cutting jigs to come back to the hospital. So we'll talk a little bit about hip arthritis. And on the left, you can see this is very severe erosive arthritis. So most patients don't suffer that long to get disease that bad before they seek help, but that can certainly happen. So if you look at the anatomy of the hip joint, it's a ball and socket joint. And so on the left-hand side of the screen there, you can see a relatively normal joint. There's normal joint spaces at the femoral head, which is at the top of the femur, the thigh bone, and the acetabulum, which is the socket side of the hip joint. And then a hip with osteoarthritis. It's the same basic thing as knee arthritis with narrow joint space. You can get all the same findings with osteophytes or bone spurs around the joint, and significant stiffness can be found about the joint as well, just the same as with the knee joint. So symptom complexes are pretty similar to knee arthritis. You have pain and stiffness, swelling, crunching or giving away of the hip joint, limping, and startup pain, which when I say startup pain, that refers to when you first get up in the morning, you first start up out of a chair, you'll have significant pain and stiffness, and then the joint will kind of loosen up over time and things will get a little bit better. So on the right-hand side of the screen, you can see this is a radiograph or just a plain x-ray of a patient with rather severe arthritis. The symptom complex from this type of clinical presentation include limping, pain in the groin or leg. Sometimes it radiates to the knee, and stiffness. Patients with severe disease often have difficulty with activities of daily living, including tying their shoes or just getting dressed. And a lot of patients will need to prop their leg up on a pillow while in bed because just like with knee arthritis, it makes the knee joint stiff. And really the most comfortable position for those patients is with the hip joint and just a little bit of flexion, because that opens up the knee joint or the hip joint and makes it a little bit less painful. And so in counseling my patients with hip arthritis, I usually try to counsel them on to their non-operative treatment options first. And these are usually reversible causes of pain, like weight loss. It can be very difficult, but it can be done even in patients with quite significant disease, and that will decrease the stress on painful joints and help the symptoms significantly. So a 10 to 15% loss in body weight can actually result in a very significant reduction in pain symptoms. And also pain medications, including anti-inflammatory medications, which are kind of the cornerstone of medical management of these patients. The downside of that is it can cause GI irritation, bleeding complication, as well as kidney problems. So you want to make sure that you are adequately counseled by your primary care doctor and make sure that you're healthy enough to take those medications. You can also, just like with knee arthritis, get injections, and just a plain cortisone shot can be quite effective. Unfortunately, it's usually temporary depending on the stage of disease. You can get days to weeks, sometimes months of relief if you're lucky. The downside is it requires an appointment with a radiologist to do the injection under X-ray, or you have to have a special X-ray or fluoroscopic suite to do the injections. They can be done in the office, but it is a little bit less accurate. And so sometimes you just don't, you want to make sure that you get the medication where it needs to be. And the best way to do that is with X-ray. Speaking of more non-operative treatment options, there are injectables, and just like cortisone, there are long-acting cortisone injections, and one of those is Zilretta, and it's just an extended release form of corticosteroid injection. This is also a good treatment option for knee arthritis. It's off-label for hip osteoarthritis, which just means that there isn't an indication for it on the label. So it still requires insurance authorization, and it's still a very safe treatment to try for hip arthritis, although it's not quite as effective, and we don't have the literature to support it as much as we do with the knee arthritis, but it's still an option. And so this is a patient with complete mechanical failure of the joint. And when you get to this point where you have chronic deformity, you have flattening of the femoral head, some sclerosis or hardening of the bone between the two joint surfaces, successful treatment with conservative treatments is often futile. It can be done, and there are some things that can be done, like weight loss and also pain medication, but the basic disease process will not be changed. So what is hip arthroplasty? This is a joint restoring procedure, and it is done because the joint has failed due to osteoarthritis, rheumatoid arthritis, post-traumatic arthritis, avascular necrosis, which is a chronic disease of the bone, usually metabolic in origin, or childhood hip disease. So the goal of the arthroplasty procedure is to relieve pain and suffering and restore function and the normal anatomy about the joint. So it's basically reconstruction of a diseased hip joint, and it utilizes a combination of advanced bearing surfaces and metallic implants to produce a stable, durable joint surface. This was initially pioneered by Dr. Charnley, and when he first innovated the procedure, it was really a maximally invasive procedure. The initial access to the joint was through the greater trochanter and posterior, and he kept these patients on bed rest for 7 days. Oftentimes they were in the hospital for a month. There were high rates of blood clots and complications, but he was the first one to do it, and he actually pioneered the procedure for the rest of us, so we all stand on his shoulders. So we owe him a lot for innovating this operation. He also pioneered the use of cement, which was actually borrowed from dentists to obtain a stable hip implant, and also clean air operating room environment techniques, and as well as the basic techniques of implantation of the hip. So we owe this man, Sir John Charnley, a lot. And so one of the most frequent questions that I get from my patients is, what is your surgical approach? Because patients want to get up and moving quicker, they want to get out of the hospital, and they want to get back to their normal routine and their normal lives as quickly as possible. So Just a few moments about surgical approaches. The workhorse, the traditional standard approach in the past has been the posterior approach because it offers the best possible exposure of the femur and the acetabulum. It's a little bit controversial, but there are some studies that show that it has potentially higher complication rates, such as dislocation. However, this is largely a controversial point in the literature. It's a little bit more difficult to reproduce the implant position precisely intraoperatively, but the advantage of it is for revision work, total hip arthroplasty around patients with a significant deformity. It is a better approach because the surgeon can see the anatomy a lot better. And then the lateral approach it's a modification of Charnley's transtrochanteric approach. However, it does involve taking down some of the abductor muscles or the muscles on the side of the hip, which can cause a limp if they don't heal properly. So that is one of the risks of that approach. And then there is the most recent innovation, which is the anterior approach, which is a modification of Dr. Smith and Dr. Peterson's approach, which was developed actually back in the 1920s. And so the theory is that there is less soft tissue disruption. It requires a special table, and it was first performed by Dr. Judet in France in 1947. And then Dr. Matta out in California really adopted the technique and helped to pioneer the minimally invasive direct anterior approach in California with a special table. So the goal of minimally invasive hip arthroplasty is less pain and a faster recovery with as few complications as possible. It's done through a smaller incision. It's a shorter hospital stay. And like I said, we try to minimize the complications as much as possible. So we know that both Judet and Matta were experts and leaders in the field of pelvic and acetabular trauma. And so they had a comprehensive and thorough understanding of the anatomy of the pelvis and acetabulum. And they really led the way for the rest of us to really get this approach, bring it to North America, and really show us how to do it safely and effectively. So the incision is anterior to the hip joint, and the surgical dissection is between the muscle layers. So no muscles are detached or taken off of the hip bones. It requires a special table. And so this is a modern Judet style table, and this is called the Hanna table. And it looks pretty complicated, but it's actually pretty straightforward to run, and it does allow for a safe surgical approach to both the acetabular side or the socket side and the femur side. And so the potential advantages of the anterior approach are less trauma, smaller incision, less pain, lower narcotic consumption, hopefully a shorter hospital stay, and some of these are actually being done on an outpatient basis, less rehabilitation required, and fewer restrictions on activity after the surgery. And so my experience and my recommendation is when approaching patients that are going to be managed with surgery, it's really a team approach with anesthesia to help us with the multimodal pain management after and during the surgery, nursing, physical therapy, the social workers and discharge planners, home health, and then the in-house hospitalists and physicians to help us really manage those patients effectively, including their chronic medical needs. So we make sure that we're addressing all the needs of the patient. And so just a little bit about pain management, because surgery is very scary for patients. There's a lot of unknowns, and we understand that you're placing a lot of trust in your doctors. So, but modern anesthesia has come a long way with liberal use of nerve blocks and spinal anesthesia to minimize postoperative pain, as well as intraoperative pain. And we've gotten much better at this in the last several years, and we've actually come to the point where we can actually limit the narcotic usage for pain control to the first 1 to 2 weeks. And sometimes some patients don't even take pain medicine after the operation because the nerve blocks and the anesthesia and multimodal analgesics that we use postoperatively is just so effective. So a lot of questions I get from my patients are, will I need physical therapy? The answer is it's individualized to the patient's needs. Usually for the first few days, patients will require some physical therapy, but the best therapy is restoration of function and minimization of pain so the patient can return to activities of daily living as quickly as possible. There's also the question of home therapy versus outpatient. I know during this time of uncertainty and COVID-19, most patients, or a lot of patients, really don't want to be out in the public spheres or in outpatient clinics. So in that case, home therapy is absolutely fine with me. It's usually covered by insurance. Home therapy is still a little bit more expensive, but for post-operative care, for physical therapy, and for any joint surgery, it's a fine option to pursue. So in summary, I would like to just say that any type of surgical intervention that we embark on with a patient is really a partnership with the patient. We have an established mutual interest, which is the best possible outcome for the patient. Our goals are really to protect patients from complications and minimize the discomfort and anxiety around surgery and facilitate rapid recovery and restoration of function, as well as maintaining open channels of communication. And with that, that would be the conclusion of my talk about hip and knee arthritis and the latest innovations. I'd like to thank you very much for your time and have a good evening.